by the GastroFoundation in association with Project ECHO and the University of New Mexico. So, these sessions are held weekly on a Wednesday. The chat is open for questions. If you have any questions, please just place them on the chat. We will also have time for questions after each presentation. So there's going to be 3 presentations. By the first one by Human Prof Bayadsi, who is one of our fellows and has joined us from Sweden. He's going to be talking on trans-arterial radioembolization versus trans-arterial chemoembolization. And then Human, who's one of our interventional radiologists, is going to speak on some of the technical aspects of trans-arterial radioembolization. And then I'm just going to briefly present a case, and I just want to discuss my thoughts on ways of trying to increase the number of patients who get liver transplants for hepatocellular carcinoma in our unit. So we're going to start with Haytham's presentation. Thanks, Haytham.
Thank you, Mark. Hi, everyone. I'm just going to try to share the screen now. Let's see that this works. Yeah. Is it working?
We can see that. Thanks.
All right. Thank you, everyone. Thank you for this opportunity. I'm going to be talking about TACE versus TARE, or TARE versus TACE, balancing cost and effectiveness. Not very used to giving talks in English, so I hope this one will be fine. Just let me know if anything is not clear, or I'm happy for any suggestions. So if we just start with an quick overview of the treatment of HCC, liver tumors in general. So there is a surgical resection, and there are the local ablative methods, and a bunch of those local ablative methods: microwave ablation, radiofrequency, cryoablation, laser, external beam, or radiation. Then we have the liver transplantation. And then we have a category that we call or refer to as trans-arterial locoregional therapy. And in this category, we have principally 4 or 5, actually, type of different methods. We have the trans-arterial embolization, TAE, and we have the trans-arterial chemoinfusion, the TAI, or TAI, and we have the trans-arterial chemoembolization, TACE, or also known as conventional TACE or CTACE. And then we have the selective internal radiation therapy, SIRT, also known as trans-arterial radioembolization, TARE. And then there is the 5th one, which can be included in the trans-arterial locoregional therapy, but it's a little bit more advanced, and I don't know how, it's not that popular internationally, but it's used especially for melanoma, ocular melanoma, liver mets, the percutaneous hepatic perfusion, PHP. So today we're going to talk about TACE and TARE. So we're going to talk about the trans-arterial locoregional therapy. So just briefly, the TAE, it's basically only mechanical arterial embolization, which induces hypoxia. There is no strong evidence that it gives any survival benefit, and the hypoxia can even induce more angiogenesis in the tumor and can be oncologically which is oncologically not that favorable. The trans-arterial chemoinfusion, the TAI, is basically just infusing the tumor with chemical agents, no mechanical embolization. So the problem that there are no randomized trials comparing the TAI with systemic therapy, and there is no difference in tumor response or survival when you compare TAI with TACE. And TAI compared with TAE cause less hypoxia and thus less angiogenesis, so maybe it's slightly better than TAE. Yeah. And then we have the trans-arterial chemoembolization, the TACE, which can be used as selective or central. which both have similar anti-tumor effects. I think my colleague Joshua is going to talk about the technicality behind TACE and TARE in his talk, so I'm not going to go into details. I'm going to leave that to him. So TACE is used mainly for HCC, but some have used it for colorectal mets or even neuroendocrine tumor liver mets. But it's not like standard, but it have been used for that. And the two main issues with TACE that everyone is talking about, and all this, there are a lot of studies about that, is like the portal vein patency, for the presence of portal vein thrombosis is a contraindication, is a relative contraindication, or it's okay. And of course, the presence of arteriovenous fistulae that should be excluded. So these are the two main issues with TACE that makes it feasible or not. The two main types of TACE is that we mentioned. The first one is called conventional TACE, which is actually a TAI combined with TAE. So it's an emulsion with lipidol molecules with a chemical agent, and then after you infuse the tumor with the lipidol emulsion, you finish your procedure with an embolization with some spongostan or particles, permanent or not, and that's the combination is called conventional TACE, and this gives the best survival benefit and is the standard treatment for the patients with intermediate stage HCC with child-PU score of A and good performance status of 0. And then there is the modified one, or the one that came a bit later, which called doxorubicin eluting beads TACE or DEB TACE with microspheres, which gives actually the same survival as the conventional TACE, but compared with the conventional TACE, it's more standardized method, gives better tumor response and less or milder effects in the patients that have more advanced disease. So it's more beneficial when your performance status gets a bit higher, your child-PU score is a bit higher, or if you have a recurrent or bilobar disease. And then some studies have showed the survival, the benefit, sorry, is with the more advanced, with the DEB TACE. So the issue with the portal vein thrombosis is that despite that there is a lack of randomized trials, the TACE can be used, and it is being used in many centers, even in the presence of portal vein thrombosis. And the retrospective studies have actually showed that the CTACE provides tumor control and increased survival up to 16 months in these patients. There's a bunch of trials, I listed them down, that show that it actually works with portal vein thrombosis. What are the main side effects of TACE? This is the most common one is the post-embolization syndrome, the PES, which is a fever, right upper quadrant pain, nausea, vomiting of different duration, can be some days or so, up to a couple of weeks post-TACE, usually mild and treatable. But there are more serious side effects as the complexity increases. So if we have more advanced liver disease, child-PU B to C, or if the location of the tumor is more central, then they give a risk of necrosis or biliary tract complications such as stenosis or necrosis of the biliary tracts or acute cholecystitis, or if the tumor volume is large. So it can cause even tumor rupture. So there are some more serious effects with TACE, and even the non-target embolization, if the embolization occurred in non-intended parts. Cardiac toxicity and anemia have been described in less than 1% of the patients undergoing TACE. There actually was an interesting study from Uppsala, Sweden, between 1998 and 2008. I think it was 101 patients that undergone TACE. Only 27% of the patients did not get any side effects. So it's quite a lot of side effects with TACE. And the other issue with TACE that when you look in the literature, the problem with TACE that is the local tradition have developed so differently in each hospital that the exact technique, for example, the frequency, the type of chemotherapy, the selection of chemotherapy administration, if we administer a final embolization or not. The embolization material, it all differs from centers to center or from hospital to hospital, even within the same country, which makes it very difficult to compare treatment results and make it standardized. So that's the problem. Although the depth TACE compared with the conventional TACE, as we mentioned, is more standardized. The other issue is the term TACE is being used in the literature in different study in a different way. So sometimes the TAI is being referred to as TACE. So that makes it even more difficult to compare different ones, different studies and outcomes. And then the other part of the local ablative radio in a local embolization therapies is a selective internal radiation therapy, the SIRT, also known as TARE, Trans-arterial radioembolization. So the embolization can occur with different yttrium-90 microspheres, and the the benefit with TARE that it can be used for other tumor types than HCC. Sorry for that mistake, it says HC, but should be HCC. Colorectal, breast cancers, ocular melanoma, neuroendocrine, liver metastasis, cholangiocarcinoma. So it's quite very good, and actually neuroendocrine liver mets. And now it's actually recommended for that, and TACE is not recommended anymore for the net metastasis in many studies and some guidelines for neuroendocrine tumors. And lately, the TARE has been recommended by the BCLC as an option for patients with BCLC stage 0 or A, or a tumor size below 8 who are not eligible for ablative techniques or resection. It can be even recommended for BCLC B patients who still have preserved portal flow and defined tumor burden. And it is even recommended by the European Society of Medical Oncology for early and intermediate stages of HCC. So TARE is becoming more and more popular. Problem with TACE is that it's more logistically demanding, as it is a two-staged procedure or 2 sessions procedure, the diagnostic one and the therapeutic one. I'm going to leave the technicalities for my colleague Joshua to go through the details with the different procedures, but it's usually 3 to 4 or 2 to 3 or 3 to 4 weeks between the 2 procedures. So in the terms of the portal vein thrombosis, and compared with systematic therapy, so there were 2 largely randomized trials that have been done in the treatment of HCC that shows that the TARE provides equivalent survival compared with the sorafenib, but it was associated with less toxicity, which is good. It was shown that it's quite safe to be used in patients with Child-Pugh-A, even in the presence of portal thrombosis. And the TARE in HCC patients gave the same long survival, regardless if the patient has portal vein thrombosis or not. But actually, it was worse survival if the portal vein thrombosis was in the main stem. But even compared to sorafenib, it was still better with TARE compared to TACE in the presence of portal vein thrombosis. So what are the side effects of TARE? The post-embolization syndrome is much less frequent compared with TACE. And the patients actually who undergo TARE, who have neuroendocrine hormone-producing tumors or metastasis, can get flush symptoms due to the rapid tumor necrosis and can be needing extra sandostatin, but it's manageable. There is a risk for liver toxicity, but it's generally very low, and it correlates with the bilirubin levels. I know that many centers, they like the patients to be non-jaundiced to give them TACE or TARE. But actually, there are a couple of studies that they did TARE on different bilirubin levels, I think up to 110. And they saw that there was a correlation with liver toxicity the higher the bilis are. But I mean, being jaundiced was not a total contraindication for TARE. There is a very rare but feared complication called radioembolization induced liver disease, but I think it was less than 0.5% or something. So the thing is that both TACE and TARE can be used as combination therapies together with systemic or other local ablative therapies. However, there are 3 big randomized studies, the Foxfire, the SIRFLOX, and the Foxfire Global, that shows that actually if you add the TARE to the first-line FOLFOX chemotherapy for patients with colorectal liver mets, did not improve the overall survival compared with only FOLFOX alone. However, there is another study, it's called Ceramic. It shows that if you combine TARE with sorafenib, and the toxicity was not greater than sorafenib, and it actually showed some benefit in HCC. But it's still, both methods can be used actually for downstaging and downsizing before resection or liver transplantation for HCC. So now not other tumor types. So they can both be used for downstaging. So this is the table, probably many of you are aware. This is the table that shows the indication, contraindication, and recommendation for treatment with the conventional TACE, TAI, and the DEB TACE, which is actual also for TARE, can be used also for TARE. And you can see there are like the absolute contraindication, there are relative contraindications, and there are things that makes you abort the treatment if one of these things happens, and what is actually the goal of the treatment, and what happens if the goal is not achieved. And you can look at 4 main different parameters, which is the liver function, the general status of the patient, the tumor burden, and the technical aspects. So like we said, I'm going to show a couple of slides further. The TARE is actually more advantageous the more you go to the right and down in this table, the more the patient is more sicker and has more technical aspects and the tumor burden. So if we talk in terms of efficacy, so TARE can be offered as an alternative to TACE. There are many studies that showed that and came to that conclusion. Because both methods have the similar overall survival. However, the TARE has the advantage that the the PVE syndrome is much less common. So it's less side effects with the TARE. And there is a study that actually from Monaco, I think it showed that TARE may be associated with a longer time to progression of HCC compared with TACE. So it gives the patients more time with tumor-free time. So there was this study comparing TACE and TARE with HCC for overall individual patient level. So it was a meta-analysis, compared 17 studies. 2,465 patients. So it showed that the current data suggesting that TARE provides significantly longer time to progress than to TACE, with a difference of almost 5 months. But the two treatment did not differ in the terms of overall survival. It's just a longer TTP time. And the safety profiles appear to be favoring TARE, but they think that there more data needs to be done regarding that. But TARE seems to be more safe and provides more TTP, but the overall survival is similar. So in terms of costs, and that's a very interesting thing, and there are a bunch of studies about that. The problem is that in order to achieve a satisfactory anti-tumoral effect, the TACE treatments need to be repeated. And usually patients undergo 2 times or 3 times TACE. Some patients maybe 4 times. But usually, in terms of TARE, 1 treatment is sufficient. maybe 2 in case of of bilobar disease, but very seldom. However, we have to keep in mind that TARE is carried out in 2 sessions, 1 diagnostic and 1 treatment, with a few weeks apart. So the upfront cost of a single TARE session is much higher, at least 2 to 3 times compared with TACE. However, if you consider the cost of hospital admission, pain control, treatment, multiplicity, toxicity, and the overall cost effectiveness, many studies have showed that TARE is likely to be superior to TACE in patients with unresectable HCC. Yeah, sorry, that was the Monte Carlo-based simulation study that showed that the cost of TARE may be equivalent to TACE in moderate disease burden and BCLC stage 4. And is more cost-effective compared with TACE in patients with more advanced disease. The more advanced disease you have, the more benefit you get with TARE. So there was another study comparing the cost-effective analysis with different loco-ablative, 3 loco-regional therapies, the TACE, TARE, and percutaneous ablation as bridging therapy to transplant. Of course, the percutaneous ablation was the cheapest and the most effective one, but when you compare TACE and TARE, it was found that in terms of quality adjusted life years, QALY, it was 2.49 for TARE compared with 2.31 with TACE, which is a difference of 3 months in compensated cirrhotic state. As you can see, the TARE was more costly compared with the TACE. The incremental cost effectiveness per QALY made TARE more cost effective. So compared to TACE, patients receiving TARE not only require fewer treatments to achieve downstaging, but also have a lower risk of tumor progression. There was another study comparing the economic evaluation of TARE and HCC, a systematic review. Reviewed 20 studies, 13 from Europe, 6 from USA, 1 from Canada, that shows that TARE was associated with lower treatment costs in 10 of the studies. And the incremental cost-utility ratio for TARE versus TACE resulted in 17,400 American dollars per adjusted QALY. And made it even more efficient compared with sorafenib. So there was another, I don't know why the slide is showing, it looked like that funny, but I think there. So the ablation costs for TARE, TACE, and the cost for TARE, TACE, and ablation, as you can see in this study from American College of Radiology, it showed that the TARE costs like about $21,000, and the TACE is about $5,100 compared with ablation was $3,700. The most expensive thing in TARE was the actual microspheres. But I mean, if you are treating more tumors or repeating the treatment like 2 or 3 times, then the cost will add up, and it will be actually similar. So what are the advantages of TARE compared to TACE? TARE is more suitable for patients with HCC with portal vein thrombosis or more advanced stage of HCC, because it uses less ischemia and necrosis. It has lower risk of PV compared post-TARE. And in patients who has early stage HCC still have preserved liver functions, but who are deemed not candidates for RF ablation, TARE provides response rates, tumor control, and survivor outcomes similar to curative approaches. One study have showed, so it's almost like curative. And although the data is not still limited because still a lot of aspect to research, but it seems that the quality of life following locoregional therapy is better with TARE. compared with TACE. And that's probably related to the symptoms. So in summary, we can say that both TACE and TARE provide similar benefits on the overall survival and delay of progression. And TARE has a wider range of application. Yes? Oh, okay, I thought somebody was talking. TARE has better health-related quality of life with lower or favorable toxicity profile. And although if you compare a single session TARE with a single session TACE, TARE is more costly, but the overall cost favors TARE over TACE for an individual patient with an unresectable HCC that's probably going to be needing 2 or 3 sessions, and in the term of the TTP. So I think that TACE is the modality that was initially developed for locoregional therapy in HCC. It has the largest body of evidence and is adopted in many centers and in many consensus recommendation and treatment algorithm for unresectable HCC. So now when TARE experience is evolving, it is very important that we should consider it more and more and add it to the treatment of unresectable HCC, and even as it has many potential advantages over TACE. Yeah, that was all. Thank you very much.
Thanks very much, Ethan. That's really comprehensive, good talk. I just wanted, there are a few questions. You know, just a comment from me. You know, we've now got TARE available, but you know, one of the things that precipitated this talk is it's not clear to me which patients really would benefit more from TARE versus TACE. So I just, well, a couple of the questions. One was a TACE or TARE, which is superior. I mean, my take on it is that it's a bit more complicated than just which one is superior, but that's you know, TACE is obviously cheaper. It only requires one session, whereas TARE might be more effective after just one session, but it's more expensive and you know, probably a little bit more cumbersome to do. If we were going to try and choose patients, who do you think we should try and do TARE on? Is it patients with bigger tumors, or, you know, the other one is portal vein thrombosis? That's the obvious one. But do you think patients with much bigger tumors also benefit more?
Yeah, I mean, well, it depends. If you're gonna start something, you're gonna do it for the first time, probably you want to do it. I mean, you have the technical aspects in the center, like if you haven't done it before, then probably you don't go directly on the patient with a bigger tumor, more bilobar disease or more complexity. But if you look in the literature, actually the patients with more advanced disease, like intermediate stage HCC, which is also defined by a the tumor size is one of the benefits there. They benefit the most of TARE. So I think the lesser tumors that can benefit maybe from one TACE session is not cost effective to do that on them. So probably the patient that you think that they might be needing TACE 2 or 3 times at least, that you probably choose for your TARE. Okay,
that makes sense. So there was another question: is survival post TACE or post TARE? I mean, I think what I got from your talk was in the studies that have been done, they haven't shown a survival difference, but you know, yeah, so we can't really say there's a big survival difference between the two.
No.
Yeah. And then,
but the tumor time to progress was longer with TARE, which means that the patient have a longer period being symptom free or having no symptoms of the tumor longer compared with TACE. So you live the same, your survival is the same, but probably with TACE, you're going to be sick of your disease all the time, or requiring treatment 2 or 3 times, or hospitalization multiple times. So with TARE, you live the same period, but you're probably healthier or symptom free more.
So there's another question saying, does post-TAE angiogenesis matter clinically if the embolization is successful to cut off the blood supply? Now, there are studies that have been done after TACE where patients get some form of adjuvant therapy. Sometimes it's a biological agent such as bevacizumab, which is a VEGF inhibitor. I'm not sure how clinically relevant it is, but obviously, the fact that there is angiogenesis after you do a TACE does mean that, that the tumor sort of reestablishes its blood supply. But that's something that then is dealt with the subsequent TACEs. I mean, that's how I would think of that. I don't know if you agree with that.
Yeah, I mean, was it about TACE or TARE, the question?
They said post TAE, so it was after TACE. I don't know.
Yeah.
I don't know if it's as much of an issue after TARE, because with TARE, I don't think you get as much embolization.
Exactly.
Yeah.
Exactly. So it's post TAE, the trans-arterial embolization only. So there was a study that done showed that you get angiogenesis because we just block the vessels mechanically and you don't administer any chemical agents. Then this angiogenesis process promotes more like tumor growth due to the hypoxia. That's why you get the benefit with the depth TACE or with the conventional TACE. You get this combination of both drugs and mechanical to overcome this angiogenesis problem.
Yeah. Okay. Thanks very much, Haitham. So we're going to move on to the next talk. As I said earlier, GastroFoundation is going to do the next talk on the technical aspects of TARE. GastroFoundation.
Thanks so much. Thanks for this opportunity. We're talking on.
Yeah, we can see that.
Okay, fantastic. So some of the technical aspects regarding TARE. So just talking about considerations and then the procedure itself. So as my colleague mentioned, so radioembolization is part of the locoregional therapies for hepatic carcinoma, especially hepatocellular, but then also cholangiocarcinoma and colorectal metastases is the common ones, and then also touch on a few other ones, just to say that in radioembolization is the local administration or the regional administration of these small labeled yttrium-90 particles. So they are quite small, they're 20 to 60 microns. It's not actually an embolization. So since it's so small, it does go sit within a tumor region and in that where it's been administered, but it's still small enough for oxygen to pass through, which is required for the radiation-induced free radical production, which breaks the DNA strands or bands, and then that causes irreversible cell damage. So that's sort of the basis on how it works. The yttrium-90 releases these beta waves, which is a very high sort of power, but short distance, so they only travel about 11 millimeters from where they are situated. So the patient itself is not a radioactive being after the procedure, really. The scatter is not as much, and then it's only a small amount of gamma rays that's been produced. And as you can see, the half-life is not that long, and after about 2 or 3 days, it is basically it's also done its job and caused the injury. So there's two types on the market. The one is called the TARE one. TARE spheres is actually what it's called. It's glass embedded with the yttrium-90, and then the other one is SIRT or SIRTX. You might come across in your reading. That's a resin that's bound on the outside by it. And then technically, the dose of gray that's administered per bead is different. So the glass one can carry a lot more gray than the SIRT ones, and that does play a role depending on what you want to achieve. So as my colleague also mentioned, the Barcelona criteria is now incorporated radioembolization is outlined by the yellow box as part of the treatment area, especially in the intermediate stage. But yeah, radioembolization is also being used now, not just for a specific indication, but also in patients who are actually candidates for liver transplant, just because of the long waiting time, often just to buy some time for that. And also then to downstage patients, if not just treating them. So yeah, just to show you the difference in the bead size. So TARE uses a 20 to 60 microns. That's the size of either the resin or the glass. And as you can see, TACE is a bigger particle, 250 to 300 microns, thereabout. And essentially, the particles, often because they're so big, just get sort of stuck in the proximal, or theoretically they get stuck proximally, sometimes not penetrating deep enough per se, whilst and then the TARE particles can actually go quite deep and don't obstruct the blood flow. So yeah, some of the indications, as mentioned, is for hepatocellular carcinoma or cholangio, metastases, which also include some of the other ones, although not commonly first or even second line. There are other treatment options, for instance, for breast. The problem also with breast carcinoma is often by the time it's metastasized to the liver, it's already gone to the bones or lungs or somewhere else. And then radiation lobectomy is quite a nice one that they also do now, especially if the tumor is confined to one aspect of the liver, right lobe or left lobe. They can do, we can do a radiation lobectomy for that site, and that also causes contralateral hypertrophy for later hepatectomy, we say. So I think my colleague also mentions often in patients where it's unresectable, or let's say can't ablate a lesion, or even if it's chemorefractory, these are all sort of criteria for patients to be included for TARE discussion. Even sometimes when you consider TACE, but the patient didn't respond to the TACE at all, it would sort of be, that wouldn't really make sense to do another TACE if it hasn't responded the first time. So then patients like that can also be considered for TARE. And then, as I mentioned earlier, downstaging or bridging to treatment or liver transplant is other options. And the other one, quite a big one, is then portal vein thrombosis. And portal vein thrombosis, especially because you don't really cause complete embolization. So there's still blood flow to the liver parenchyma. So the blood flow is not completely cut off. Yeah. So then these are sort of the steps one would consider. So firstly, just clinically evaluate the patient, determine if the patient's eligible for the procedure, if he falls into the right category. And you don't necessarily want to do a treatment for a patient that doesn't have a long overall survival. Yeah, if it already looks like the patient's really not a good candidate, then it would not be economically sound to do a TARE procedure. And the next step would be to obtain some form of cross-sectional imaging, albeit CT or MRI, and quite recent, so within, I would say, 2 months. The next step would be then to do angiography. So that would be the first step, and I'll just touch on that briefly now, which would encompass the planning procedure. During that time, administering the technetium-labeled macroalbumin. And from that, they would do with nuclear medicine. One would sit down and determine the actual dose of the treatment that one is going to administer, and make sure that there's no non-target embolization, especially to the stomach. That's a common one that needs to be, any of those collaterals needs to be embolized. And the other thing would be determining the hepatopulmonary shunt, was if it's more than 13 gray, there's a high risk of causing radiation pneumonitis. And then, yeah, the patient will come back it's quite a technical thing. So normally it's about 2 to 3 weeks. It just depends on how quickly the planning can be done and how quickly one can order the yttrium. And then next step would be to administer the yttrium exactly the same way as you did your first angiography. You administer the technetium. And then afterwards, yeah, the patient goes again to nuclear medicine straight after for a SPECT or a PET scan, just to determine to verify basically your administration. So these are sort of the limits for patients, at least a performance status of 2 or better. And then platelets must be about 50. If the renal function is off, consult a nephrologist. And then bilirubin should also not be too elevated. These are all sort of indications or parameters just to limit any form of liver disease, underlying liver disease, or something that needs to be corrected. Otherwise, the insult might be too big on the liver. And then also say non-massive ascites. And then especially there can be some metastases, some centers are okay with. So a little bit of few lung nodules or sub-centimeter local lymph nodes, and at least not diffuse bone mets. I think that's all to do with the overall survival of the patient and being a good candidate, not economically wise as well. So at least to make a difference with your treatment. And then a significant extrahepatic disease would be a contraindication or poor baseline. And then also when you do your technetium labeled albumin, to make sure there's not a big pulmonary shunt. And also if you see when you did your technetium delivery and you go through the imaging, the specs afterwards, just to make sure that there wasn't any major non-target embolization. So that would be a contraindication. If you won't be able to safely deliver your yttrium, then it wouldn't be good. And then, yeah, the max or single treatment lung dose should be at least less than 30. And then in the lifetime, total dose should be less than 50 gray, cumulative. Yeah. So this is just an image to show how they administered the albumin to the liver, and then just determine the shunt. So they measure the amount of radioactivity that goes to the lungs. So this is all part of the planning process, and this hasn't been the actual yttrium delivery. And then just make sure that, yeah, the shunt is not very big. These are some complications, just to mention them, that might occur. So the biggest ones, the common ones first, so that's non-target radiations, like to the stomach, if you have like one of those archites from the left gastric, or your takeoff of your GDA to your, say, hepatic artery is not very far. It might even go down there, and that can also cause non-target radiation. And then radiation pneumonitis, the big one that just need to look out for, and one can really easily measure that and prevent that. Biliary complications, they say, are quite rare, but one should just be aware of them. And they normally be treated conservatively. And then radiation-induced liver disease, but yeah, that's also controllable by just doing the correct measurements beforehand, making sure you don't overdo it, and especially in a patient that doesn't have underlying, severe liver disease. All right, so now you've selected your patient for TARE. How would it actually work in the procedure? So yeah, it's a 2-step procedure, as mentioned. And like mentioned, it takes could even take 3 weeks just to get all the logistics in order, the planning and ordering the yttrium. And then, yeah, it can actually be done as an outpatient procedure, but often one can just, maybe for a day after or the day before, but doesn't necessarily have to. And then, yeah, first step would be to perform on the day hepatic angiography. So in the cath lab, one would either access the radial artery or the common femoral artery. One would delineate the vascular anatomy. you would localize your tumor, so going through the vessels and making sure that your delivery would encompass the whole tumor, embolize necessary branches that might be in the way, and then one would deliver in that position your technetium labeled albumin. So in this case, the patient had a MRI beforehand. So the left image shows hypervascular tumor right at the dome of the liver with in the portovenous phase nice washouts, following the proper Lineage criteria. During the angiography, one can, just because it's on the dome of the liver, it's maybe some bit of difficult to see, but it appears to encompass the whole tumor. It's hypervascular in nature, and one can actually, they can sub-select, sort of segmentally deliver what they need to involve the whole tumor. So just look closer. And then after administering the albumin, the patient will go to the nuclear medicine department, and one would try and work out the tumoral uptake, measure the ratio from the liver to the tumor, apologies, just to make sure how much is actually going, basically how vascular this tumor is and absorbing most of the particles. And there's the right image here, is basically just showing the SPECT workup and measuring how much was taken up by the liver, so, by the tumor itself. So the red is basically mostly where most of the albumin was taken up by, and then they can also measure around where the blue is what was to the rest of the liver. So especially on this coronal image, you can see there's some going a bit more to segment 6. Say, so just to note, but the majority will actually go to the tumor itself. Then ordering the actual either THERAspheres or SIRT, depending on what your department or your hospital would buy. And this is sort of how it looks like. And this container just prevents any radiation outside the actual beads, and this is how small they are compared to a hair follicle. So, so then the second step, again, back to the cath lab, do exactly the same thing. Try and position your catheter exactly where it was previously, and by administering the tumor, this was now cone beam CT, just to make sure it encompassed the whole tumor and uptake by the tumor. And yeah, so afterwards the patient will go back to nuclear medicine as mentioned, and just to measure then the actual yttrium on the SPECT or PET scanner. This was just all the imaging together. So this was pre-treatment, the actual administration, and then the follow-up, which then actually shows atrophy in that segment, since it was a segmental type segmentectomy almost. So another case that I wanted to show. So this was pre-treatment. Again, similar principle, doing the angiography and determining the actual tumor, the take-up of the tumor in that, say, lobe or segment, and then the treatment, the follow-up. So in this case, this was over a period of 4 months to 6 years, actually. So there was tumor initially. One can see this being the left lobe. The tumor was in the right lobe. And then subsequently, there was atrophy of the right lobe. Initially, there was also portal vein involvement with decreased flow. And then about 4 months later, there was already flow again. And then images E to F actually shows the atrophy of the right lobe. So this area here is not the right kidney, it's actually the right lobe of the liver. There's a bit of kidney sticking out there. And then coming lower down, one can see there's the majority of the kidney, but then marked right lobe atrophy and significant left lobe hypertrophy following following this procedure. And then this was a case also of a tumor up in the dome of the liver, which they identified, treated, which you can see this was post-procedure, so no take-up within the lesion itself, and then this part of the sort of segment or almost lobe of the liver was involved and treated with radioembolization, and the patient subsequently had a right hepatectomy, and again one can appreciate the marked left lobe hypertrophy that followed. Thank you.
Thanks very much, Joshua. Just a question from me. So there's the two different sizes. The TARE spheres, are they the smaller ones?
TARE spheres and SIRT are, yeah, I think TARE spheres are slightly smaller, but both of them are less than 60 microns.
So they both don't cause embolization.
That's right. The only difference between the two is the amount of radiation they can carry. So the TARE spheres can carry a lot more gray than and so that's more the preferential particle one wants to use to do something like a lobectomy, a radiation lobectomy or so.
Okay, so are there occasions where you'd prefer to use the SIRT?
I think some people, I think you can use either. So there's not a one. It's just a radiation delivery that's a bit different. But I think in the majority of cases, not necessarily that you want to use it rather than TARE spheres because they're too strong. Yeah.
Karan Gandhi apparently has raised his hand. Karan.
Yeah, hi Mark. Thanks. Thanks for your talk, Joshua. I just had a question, or maybe others can answer it. I know the Barcelona talks about doing TARE for lesions less than 8 centimeters and when they're solitary single lesions. But from your talk and what I imagine, if you've got a multifocal HCC, say you've got 2 or 3 lesions in the liver, don't you think it would be possible to selectively radioembolize 2 or 3 lesions if you have no extrahepatic disease, rather than just subjecting those patients to sort of systemic therapy? I don't know. I think there's a future in that for radioembolization. I just want to hear what others think about that as well.
But so my understanding is that TACE or TARE are options for patients with intermediate stage disease, and so that would include patients with multifocal disease. Gersha, would you be able to do TARE if there were multiple lesions all over the liver?
From what I've seen, is that they are able to do that. So they'll. It all comes down to dose delivery of the gray. The tumors are hypervascular, so they tend to absorb most of the radioembolic. So I haven't done anything myself, or I haven't practically seen it myself, but I've seen it in literature that they do that. Yeah.
And when you do the TACE, like most of the, like if you do a DEB TACE, you tend to use more or less the same dose every time, if I'm not mistaken. So with this, like if there's one lesion, do you use a lot less than if there's like multiple? So is the radiation dose massively different?
It is different, yes. Yeah, it is different. So you basically, when you do the technetium albumin delivery, you determine how much is being picked up by the tumor versus the liver itself. And then they work out what's the type of dose you would need, determining on how large the tumor is, etc. And then you order a specific amount of the dose. And then you only use basically some of the thing they send you is the correct dose that you order. So it's not like a standard 150 gray or whatever. It's say 40 or to 24, depending on what you
so if there's like multiple lesions all over the liver and there's a maximum dose that you can use, then you might be, each one of those might be treated with quite a lot lower dose than if you just had one lesion. Is that correct? Okay. All we sort of almost come to the end of the time. So I'm not going to really have time to do my talk. And I think it actually works quite well because we've covered TARE. My talk was sort of on a transplant topic. So I think we can carry that over to next time. If there's any, are there any other questions? If not, then I'd just like to say thank you to the speakers, and say thank you to the ECHO University of New Mexico team and the ECHO India team. The recordings are available on the GastroFoundation website. Thanks to the GastroFoundation and to the presenters and to our sponsors. And I've been asked to tell you that next week is PBM. I'm not actually sure what PBM stands for, but that's next week. Thanks, everyone.